Hello, we would like to welcome everyone to Your Nurse Advocate. And we are having a conversation with Ken Schmaling today, and we are going to be talking about the importance of getting early care when you're showing some signs and symptoms of a stroke. So joining us is Ken, and Linda and I are both here today. So we're going to be presenting this topic to you. So I hope you'll gain a lot of information, and we're going to go ahead and get started. So we brought Ken with us because Ken has 25 years as a Kenosha Fire Department down in Kenosha, Wisconsin, serving as a fire captain and a paramedic. He's now retired, but he's graciously agreed to come on with us today and share his knowledge from a first responder perspective in caring for people with having a stroke. So we look forward to hearing from Ken and all his words of wisdom that he'll be sharing for us today. To get started, we just want to talk about there's actually two types of strokes, but we're going to call it three because a lot of people have questions about a TIA. So we're going to get into that. But what's real important, one of the things Ken will talk to us about is, the pre-care, the care that goes into that you get before you go into the hospital. And when we're looking at the different types of strokes, it's important for your provider and for everyone to know the different types because they will have different treatments. So the most common, or what they say, 87% of the strokes are what they call ischemic stroke. And what that means is there's some kind of clot that blocks an artery in your brain. And depending on how big the artery is and where it's located will determine the type of symptoms you have, how long you have them, if you have a full recovery, or if you're going to be left with some symptoms. When there is a blood clot that clogs the artery and actually causes the stroke, that's when we're going to use the clot buster medication. And we're going to talk a little bit more about the golden hour and how important it is to get fast treatment. But this would be the treatment or the type of stroke that we would want to go in with clot busting medications to bust up that clot. The second type of a stroke is a hemorrhagic stroke. And Ken's going to talk a little bit about the importance of what to do and what not to do when you're having some stroke symptoms, because with the hemorrhagic stroke, that means that a blood vessel in your brain, an artery, has burst. So you're bleeding into your brain. That's causing pressure on your brain, and that's what's causing the stroke symptoms. Obviously, you're not going to want clot busting medications or anticoagulant medications that are going to cause more bleeding when you're already suffering from a hemorrhagic stroke. So you have to be very careful with that. So that's one of the key things that's identified in that golden hour is what type of stroke do you have? The third type of stroke is people refer to them commonly as a TIA or a trans-ischemic mini stroke. So like the ischemic stroke, it's very small. The artery may only be clogged for, partially clogged, or a clot, is working its way through, and it's smaller that it doesn't get stuck and block, but it's there long enough to cause some symptoms. A lot of times the blockage may last for only about 5 minutes. And oftentimes these patients will come into the emergency room, and by the time they get there, their stroke symptoms have already resolved. But the important thing is you don't know that when you experience the stroke symptoms. You have no idea if it's a full-blown stroke or if it's a TIA. So you have to treat every stroke symptom seriously as if you were having a full-blown stroke. And the important thing is when we're talking about the TIAs is that some people, kind of poo-poo them, so to speak, or don't take them seriously, and are hesitant to get treatment because everything resolved. But they say as many as 10 to 15% of people will have a major stroke within 3 months of having a TIA. So that's really important, and that more than a third of people who have a TIA and don't get treatment will have a major stroke within a year. So one of the things that we teach lay people, so to speak, or people that are not in the healthcare field, is we teach the FAST scale. So when you're looking at recognizing symptoms of a stroke, you want to think fast. You have to think fast. You want to get to the hospital as soon as possible. So we look at F. F stands for face. So if you're with someone, you may want to ask them to smile, check for facial droop. If they're smiling, one side isn't going to, turn up. That might just droop down. So you want a good way to assess that is by asking the person to smile. Then you have the A for arms, and you're going to ask, the person to hold out their arms in front of you. And usually if one side or the other is affected, that arm, that side that's affected will start to drift down. You won't be able to hold them out straight, steady. One will start to fall down. So that's the second part, or that's A for arms. The third letter, which is S, stands for speech. So ask someone to say a simple phrase. If their speech is delayed, if it's garbled, if they are having trouble getting the words out, this also would be an indication that they may be experiencing some stroke symptoms. And then T stands for time. And if if they're seeing any of these symptoms, it's very important to call 911, because as we're going to talk about in a couple minutes, we have a golden hour of opportunity to treat the stroke when actually we can stop the damage and lessen the effects. So really, really super important with an ischemic stroke. And before we move on, Ken, is there anything that you would like to add or say about the FAST scale or how it's used in the pre-hospital setting?
You've given a very good explanation of it. It's the same type of thing that we would do in the field when we come to the house, is this quick evaluation to try and get a handle on exactly what kind of symptoms they have. But the most important part, as you've emphasized a couple times, was time. Make sure not to delay. Even, you may think the symptoms don't seem severe and you want to blow it off, but time is of the essence. And it doesn't hurt to go in and get an evaluation, and if things work out and it's not a stroke, that's great. But you don't want to roll the dice and take a chance on having a serious problem going on and ignore it.
Okay, thank you. So we're going to let Ken share a little bit about his expertise in what to do in that pre-hospital and once that 911 call is placed. So I'm going to go ahead and turn it over to Ken, and he's going to share a little bit about that pre-hospital care that you'll need.
Okay, as Pam has emphasized a couple of times, early intervention is definitely the key. If you are having symptoms or you're noticing a loved one that's having symptoms, you want to act without delay, because time is of the essence. It's always best to call 911 rather than trying to take a person to the hospital yourself, because the first responders can provide treatment en route to the hospital. They're able to call the hospital and give a report so that the doctors and nurses know the situation at the time that you get to the door of the emergency room. They'll have a bed available. Everything will be clicking along. You'll have a team in the room already when you arrive, where if you just drive in by yourself, they're starting cold when you walk up to the registration desk. So you're severely delaying your ability to get treatment by not using 911. When you call 911, the emergency dispatcher is going to ask you for quite a bit of information in order to relay that to the first responders, including a description of the symptoms that the patient is having, time of onset of those symptoms, which is very important, because particularly with an ischemic stroke, if they're going to be giving any anticoagulants or whatever down the road, time is of the essence. You can only give that within a very specific window. They're also going to ask the patient's level of consciousness, if they're having any pain, and what the level of that pain is. They're going to ask about what their last oral intake may have been. All this stuff is very important, because they'll relay that to the first responders. And when the responders arrive on scene, we'll ask probably many of the same questions, but we're going to be particularly interested in what the patient's medical history is, if they have any conditions that might have contributed to this, hypertension, history of clotting problems, or anything like that. We're going to want to know whether they have any implanted medical devices. like an ICD, you know, an implanted cardiac defibrillator or something like that. And we're definitely going to need a list of their medications and dosages, and their medication allergies. We also need to know what time they last took their meds, and what their last oral intake was, if they've had breakfast or anything like that. But it's one good point that a thing that's very handy for first responders is something you can do in advance, and that's to make up a list, a comprehensive list of your personal information, medical history, medications, dosages, and the frequency, medication allergies, your doctor's name, you know, even your own doctor's name and contact information, and also your own personal information, name, address, date of birth, and have that on a piece of paper that you have extra copies of, so that when first responders come, you can give it to them. If you're at the hospital and the staff wants something, you can give one to them, and make sure to keep it up to date. But it's a huge time saver and a very valuable resource for any first responder, because primarily our concern is time. So when we arrive on scene, we identify that it appears to be a stroke. We're going to be basically loading and going as quickly as we can in order to preserve that time window for the patient treatment. And we'll be providing all this information to the hospital when we're en route by radio. And as I said, so that they will have a stroke team on hand in the room when we come in the door with the patient, so they'll get immediate care.
Awesome. Great information, Ken. And, you know, with that window, we just, you know, it's so valuable to know when those symptoms started. And unfortunately, some people will wait. It might be that night before they go to bed and they're feeling kind of off, and in the morning it's not better. Though that's really important to know, because that could add 8 hours to the window of opportunity. And so it's very important to know what time, you know, exactly that you notice those symptoms starting. Linda, did you have something you wanted to share?
No, I think that it is time, as as both of you have mentioned through the beginning of this webinar, is that time is of the essence. And one of the things in the post-acute area, such as home health and in discharge planning and working with individuals in the community with advocacy, one of the first things that's really important that we do is actually instruct families, especially if there are comorbidities such as heart disease, hypertension, diabetes, or issues with clotting or immune disorders in regards to these stroke symptoms, because delaying treatment actually can affect the overall outcome and your future. So we want to make sure that all individuals that are helping care for this individual in their home, or they themselves, understand those symptoms, and that time is of the essence. One of the cases that I remember most significantly was an advocacy case about a year ago, and the individual was having stroke symptoms and she did not recognize them. Her husband actually just thought it was, you know, that she was tired and that she was fatigued and maybe coming down with something. So they delayed. They did not call 911. They sat there, they kind of just watched television, had a little coffee, even though she was drooling and the coffee was not, she was not able to swallow it. Finally, they realized that something was wrong, and he drove her to the hospital. By the time she got to the hospital, he had to go through registration. There was no stroke team waiting for her when she got there. There was no one prepared to start that golden hour treatment when she got there, because as Ken had stated, you have to go through the whole process. So once they got her into triage, they realized that she was actively having a stroke, but they delayed. So that precious golden hour was now out there by about 3 to 4 hours before she actually was starting to receive treatment. And her outcomes were very different, or per what the physicians had stated and her rehab specialists had stated, her symptoms and her outcomes were very different based on the fact that her care was delayed, and she did not utilize that precious time in calling 911. So it is extremely important to utilize that time. because time is of the essence.
Thank you, Linda. So that is a great lead into our golden hour. So it's 60 minutes is that golden hour. And the next slide that we'll talk about will actually break it down for you. But we have an hour to determine the type of stroke and to get you treatment. And that's from, you know, the time that you're picked up by EMS and you get to the hospital and you arrive and the clock is ticking. So they're hoping, you know, in that window of time, they're hoping that, you know, you're transported to the hospital, you know, within 10 minutes of arrival. And I don't know, Ken, have you been instructed on a time frame? I know you said you load and go pretty quickly, but I didn't know if there was any criteria that you have for a stroke, or if it's just to move as quickly as possible.
I mean, the golden hour is, you know, a valid concept. Obviously, it's about recognizing the symptoms that the patient is having and then expediting transport. Basically, like I said, it's considered a load and go situation because you know that things are happening, and I mean, you need to stabilize the patient if they're in distress, having difficulty breathing, whatever. You're going to address that before you transfer them from their home to the ambulance. But beyond that, you're going to get them moving as quickly as you can. Establish an IV en route. You're going to do your cardiac monitoring, and that's basically going to be as much as we can do in the ambulance. You know, the real key is recognizing what's going on, collecting the pertinent information, and transmitting it to the hospital so that they can have the stroke team right there. And they will. There'll be a team, you know, numerous people in the room, doctors and nurses and whatever, ready to treat this situation, evaluate it, determine what type of stroke it is, whether it's ischemic or hemorrhagic. And
Ken, is there anything you recommend that we look at as far as what they should do or not do when they're having symptoms of a stroke?
Well, as Linda mentioned, definitely do not want to just ignore it and go to bed. If you feel that you're having symptoms, or you know your loved one notices that you seem to be having symptoms, you need to deal with it right away, because any delay could leave you with lifelong limitations from the stroke effects. And the other huge thing again is do not. I mean, a lot of times a stroke will present with a severe headache, and the last thing you want to do is take aspirin or any kind of anticoagulant, because if it is a hemorrhagic stroke where it's bleeding in the brain, it's going to make that bleeding worse, and it's going to make the stroke worse. So the number one rule is give nothing by mouth once you notice that someone's having symptoms.
Thank you. Linda, did you have something you wanted to add?
Yeah, you know, it's interesting because I got involved with this, the example that I had spoke with you about post hospitalization, post rehab, in regards to being this individual's advocate post hospitalization. And one of the things her family had stated to me in our assessment conversation was, we really wish we would have listened to her symptoms. And that was really that was a very strong comment, because they had seen things on the news, they had gotten pamphlets from doctors in regards to this, but they really, when it was occurring to them, they really didn't think through that this could be a stroke. And a lot of times we do, as you know, people will delay it because they are in denial. They're in denial. This isn't happening to me. This can't happen to me. But one of the things that she absolutely regrets, or that the family regrets, is that they did not listen to those symptoms.
Thank you, Linda. So I'm sorry, Ken, go ahead.
Well, I just wanted to help emphasize that point a little bit, because it was very common over all my years in EMS that you would go to a house and the people would be there and they'd be, oh, we're really so sorry to bother you. You know, this has been going on and we were a little worried. We didn't want to call, but we've been told that we should. So we hope it's not too much trouble. And, you know, it's like, don't think that way. And I always told people, you know, I would much rather come out here and find out that what's going on is not important, something you can ignore, than have you not call me and really need me. So, you
Mhm.
know, don't ever hesitate to call 911. That's what those people do for a living. They're there, they want to help you, they're available to help you. And
Mhm.
it's just so important that you not poo-poo if you're having some symptoms or whatever. You need to take it seriously, have it checked out, and
Mhm.
you know that your outcome is going to be the best in all situations by doing that.
Great points. Briefly on this slide, we talked a little bit about the main ones, but just to run through some of the subtle symptoms you may have experiencing when you have a stroke: numbness in an arm. Maybe you can't move your arm, or your hand isn't working right. It's so much weaker than the other one. Confusion, blurred vision, double vision, trouble seeing, trouble walking. Maybe you feel out of balance. Ken mentioned a few times about the headache. Maybe you feel dizzy. Again, the trouble speaking, and as I mentioned, the loss of balance. So in that golden hour, so it's a 60-minute period of time where they want to get you into the hospital. They need to get a CT scan. We're going to talk briefly about that. They need to get some blood work to make sure that they could give you the anticoagulant medication through the IV if it is determined to be ischemic stroke. So there's a lot of things and a lot of assessment that the things have to do. Now, if anybody's been in the hospital, had a CT scan, I mean, you know, those things don't happen in 5 minutes. So that's why they set the standard of the golden opportunity, or the golden hour, to be able to get all these things done. Because if you are truly having an ischemic stroke, they have ideally a 3-hour window from the time onset of symptoms, not the time that you arrive from the hospital, but from the time your symptoms start, to give you IV medication, which we call a TPA, to be able to bust up that clot. By busting up that clot, you're going to open up, you're going to get the blood flow back to that area. You could reduce the amount of damage. You could actually stop the stroke from occurring, and your recovery is going to be so much different if they can actually provide that medication and stop what's occurring. If not, it could continue. The stroke could continue to spread, continue to cause damage in your brain, and you could have more severe symptoms than if you have gotten in there earlier. So I just wanted to say that is where that golden hour comes in. So just to break it down, this was a really good slide I found from a nursing journal for intensive care nurses. And it actually broke it down. So from the time the door to physician, so they want, they're hoping to get, by the time EMS picks you up and gets you there, they're hoping for a window of 10 minutes or less. And the stroke team, from the time that you're getting your EMS evaluation, is 10 minutes or less. Then to the hospital is 15 minutes. They're looking to get their stroke evaluation done. The stroke team is ready for you. The door to completion of your CT scan is 25 minutes or less. And then they're allowing, so it could be up to 45 minutes to get the CT scan done, plus get the results read by the radiologist so that they know what kind of stroke that you're having. And then the door to treatment with the fibrinolytic treatment, the IV therapy, the clot buster, the TPA medicine, is 60 minutes or less. So besides the CT scan, sometimes what we'll see in the hospital is the CT scan might read negative. Maybe it was a small enough stroke or a TIA that already opened up, that the CT scan wasn't showing it. So, I mean, that's a good thing in many ways. But if you're in the hospital, oftentimes with a TIA, they're still going to bring you into the hospital for an observation period. Even if your symptoms are gone by the time you've gotten through your ER evaluation and are admitted to the acute care floor, even if your symptoms are gone, chances are they're going to keep you overnight, observe you, run some more tests, and make sure that this isn't something that's going to be recurring, or if this isn't a precursor to a larger stroke. So if they don't see anything on the CT scan, and maybe your symptoms aren't resolving as quickly as the doctors might expect when they're ruling out whether or not it was just a TIA, then they may go to the next level of a scan, and that would be an MRI. An MRI oftentimes can show some things that may not have showed up on the CT scan. And the last thing that they may do as diagnostic is to do a carotid ultrasound. Your carotid arteries in your neck, I mean, oftentimes if those are clotted or plaque builds up and they get occluded, and they're going to look for that carotid ultrasound to give an idea about what the percentage of occlusion, those carotid arteries may have. And then if they do show some, plaque buildup that's limiting the amount of oxygen, they may look at cholesterol medicine, which is going to be looked at with strokes as well, but also like an anticoagulant that they use for those carotid artery plaque buildup would be a medication called Plavix. So depending on the type of stroke that you had and in your recovery and to want to prevent further strokes, they may prescribe some different medications. Obviously, if it was an ischemic stroke, they're going to look at anticoagulants, aspirin, maybe the doctor, and the doctor, this is not a one size fits all. It depends on your history, your cardiac history, all those other disease or illnesses that you have. The doctor is really going to have to look at your complete medical history to see what type of a protocol would be best suited for you to try and prevent a future stroke. We talked about the Plavix or the clopidogrel, that's the generic name. Warfarin or Coumadin is a blood thinner, Xarelto and Eliquis. Oftentimes those blood thinners, the Warfarin, the Xarelto, and the Eliquis, are used when you have a heart condition called atrial fibrillation. And that's when your heart is beating irregularly. And what happens when your heart beats irregularly all the time, you're more prone to have stickiness to your blood vessels and can promote clots. So if you do have atrial fibrillation, you are at greater risk for having a stroke. So if you've been told that you have atrial fib, that is the reason why you're being asked to put on anticoagulants, is to help prevent a stroke that could be caused by your atrial fib. One of the things is, in a hemorrhagic stroke, one of the big culprits that causes those blood vessels in your brain to burst would be blood pressure. So again, based on your history, the doctor is going to need to choose the best type of protocol, whether it's a water pill or a combination of water pills and the different type of blood pressure medicines. There's beta blockers, calcium channel blockers, ACE inhibitors, there's all kinds. So the reason why I'm mentioning this is not that you may understand the differences, but just to know that it's not a one size fits all. So if you're having blood pressure and you don't want to go to the doctor, and your wife is on metoprolol for her blood pressure, that does not mean that that's the medicine that you should be taking. So it's a lot more complicated than that. So please, you need to seek medical attention, and your doctor will choose the best form of treatment and choose the best blood pressure medicine for you based on your history. The stroke recovery, as we continue therapy, once the stroke is over with and it's time for you to go home, and the doctor has decided on the type of medication therapy that you're going to use: physical therapy, occupational therapy, speech therapy, all the therapies, depending on what residual or what symptoms you're left with after you experience the stroke, is going to determine what kind of therapy you need. Whether you need, if it's severe enough, you may need to go to an acute rehab facility or treatment. A nursing home would be considered rehab, or if it's severe enough, you may have to go to another hospital setting, which would be a rehab hospital, to get even more aggressive therapy, where you're getting up to 5 or more hours of therapy per day to try and get you to a point where you could even maybe have to go to a nursing home for a lesser amount of rehab, or if you can go home after that. Controlling your cholesterol, because that plaque buildup can cause those clots, could break off, get lodged somewhere, and cause that ischemic stroke. So before we move on, I think what we're going to do is have Linda talk a little bit about the post-stroke care that you may be seeing once you're ready to go home from the hospital.
Yeah, thanks, Pam. Usually what happens post-stroke is that initially, based on the symptoms or what the outcomes were of the stroke and whether you were able to reach that golden hour or whether you had more progressive symptoms will determine where your rehab starts. Rehab usually will start in the inpatient unit in the hospital, and then you would be either going to a subacute or what they call long-term acute hospital, or you would go to a rehab community where you would have intensive therapy and nursing to manage medications and manage your overall therapy to get you back to a baseline so that you can go home. That therapy can go anywhere from 14 days to 30 days to 45, all the way up to 90 to 100 days of actual inpatient therapy. Once you're released from an inpatient rehab facility or community or subacute community, you'll go home with usually home health. Home health will provide you with a nurse to manage your medication, to assess the home surroundings to make sure that the surroundings are safe and appropriate for care at home. Therapy will come in the form of physical therapy, occupational therapy, and speech therapy to evaluate your need and the length of time you'll need therapy at home. Home health is episodic and intermittent, so you will not have someone there 24 hours a day. A nurse will come in based on the amount of frequency of time she feels is appropriate for your recovery. Therapy will do the same. Once you have met all your goals in therapy for home health and nursing for home health, you will be discharged from home health. If your physical therapist or occupational therapist feel that you need more therapy, you will then be sent to an outpatient rehab or outpatient physical therapy arena to continue your therapy on an outpatient basis until you get back to baseline. Just note that the sooner that you get treatment in that golden hour, the better chances for a best outcome will occur, and the less time you'll have to spend in any of these scenarios in post-acute care, whether it be an LTAC, whether it be a rehab hospital, whether it be home health, and also outpatient therapy. We want to get you back to baseline, but that's going to be based on the type of stroke and the outcome that you've had, and based on what was able to be done during that golden hour, or whether you were able to achieve results during that golden hour based on the time. Again, time is of the essence. So home health, rehab are all there for you. Your recovery will be based on the symptoms and based on the outcomes of the type of stroke that you've had, and whether you were able to actually meet that golden hour treatment plan. Other than that, you'll be followed by your physician and also a neurologist and possibly a cardiologist and probably a vascular surgeon after your hospitalization. So you'll have several physician appointments that you'll coordinate your care with your home health providers to make sure that you're getting the appropriate amount of follow-up in the community once you're home. And of course, home health will be teaching your family and you about symptoms to make sure that a new stroke does not occur, what to look for with another stroke. We'll be managing your medication, teaching you how to use them, side effects, adverse events, and helping you walk that journey to get back to baseline.
Thank you, Linda. Ken, is there anything, as we're coming to a close, is there anything that you can think of that we might have missed, or anything that you've thought of that you would like to share before we wrap things up this morning?
No, I think done a real good job of covering everything. The biggest takeaway is, if you're having symptoms, don't ignore them. Act quickly.
Thank you. I just want to thank both Linda and Ken. We really appreciate you coming on with us today and sharing your expertise. It's really nice to know, as nurses, Linda and I are very, very used to, we both had experience in the ER. So we know we've worked very well with the EMS, but we meet them when they are there. And it's been so helpful to have you share your perspective of what it's like, en route to the home, and once you get into the home, and the things that occur and what you need, prior to the patient being transported to the hospital. So we really appreciate your expertise. So just wanted to make sure we're going to, that everyone has an opportunity. Feel free to subscribe to our YouTube channel. We'll have this up for Stroke Month. And so we really appreciate you stopping by and spending some time with us. And with that being said, I just want to thank everybody for sharing and joining us for this information.